Good morning and welcome to the Sunday TE session.
Good
This
morning,
is the
sir.
breakfast session being conducted under the forum of cardiac anesthesiologists. I would like to invite Dr. Parimala and Dr. Jatin Narula for taking us through today's session. Dr. Parimala is a senior consultant in cardiac anesthesia at Jayadeva Institute of Cardiology. She is a professor. And Jatin, I think most of you know, is upcoming cardiac anesthesiologist currently working for the Amrita in Delhi. So with that introduction, I request Dr. Parimala to conduct the meeting.
Good morning, sir. Good morning, everyone. It's my pleasure to invite Dr. Jatin Narula for this session on aortic valve assessment by TE. You can please start the session, sir.
Right, ma'am. Thank you so much. I hope my slides are visible. And
yes, they are visible. They are visible. Just blow it up. Yeah, that's.
yeah. Thank you so much, sir, for giving me this opportunity. And it's always lovely to start the day with some academics. So here's the topic for today's Sunday session for the aortic valve assessment for So the topics which will be covered over the next 30 to 45 minutes are anatomy of the aortic valve, the concept of aortic root, various echocardiography views which are used to evaluate the aortic valve. I would like to highlight upon a stepwise approach to identify various pathologies, and then coming to assessing the aortic valve using various echocardiography modes like the 2D echo, the Doppler assessment, then understanding the normal flow dynamics and some basics of 3D echocardiography. Along the presentation, I would be having some questions, so please feel free to send the answers in chat box. Mudita sir, maybe in future we can have involve a prize session for or anyone who sends all the answers as correct.
Sure. We'll do that. Thank you.
Coming to the anatomy of the aortic valve, as we all know, it's called the semilunar valve, and it has got three cusps, which are named according to the coronary arteries, which are associated with it. It's the right coronary cusp, then the non-coronary cusp, which is not associated with the coronary artery, and the left coronary cusp. Each of these cusps have a nodule of Arrhenius, which is a tiny nodule at the center of free edge of each cusp, and the other structure that is important to assess are the lanulas or the free edges of the cusp that span from the nodule of the Arrhenius to the wall of the aorta. When the lanulas of the cusps are opposed and the nodule of Arrhenius is coapted in a normal aortic valve, the aortic valve is said to be completely closed. So coming to my first question is that why is the aortic valve called a semilunar valve? As I said, you can please put forward your answers in the chat box. We'll be discussing towards the end. So it's important to understand the concept of aortic root as a functional unit. The aortic valve, the aortic root acts like a basic stent into which the valves are attached in a curved manner, and they extend from the basal attachment of the cusp within the left ventricle, which is known as the basal ring or the ventricular aortic junction. That is referred to normally as the aortic annulus, and they span from this aortic annulus to their distal attachment at the sinotubular junction. So it's important for all the components of this aortic root, which is the annulus, the aortic valve cusp, the leaflets, the sinus, the sinotubular junction, the coronaries, and the ascending aorta, to perform in synchronous manner for an adequately functioning valve. So the American Society of Echocardiography has recommended four views, which is the mediastinal aortic valve short axis view, the mediastinal aortic valve long axis view, the transgastric long axis view, and the deep transgastric views as bare minimum for assessing the aortic valve. And we'll be discussing all these views individually. The mediastinal aortic valve view, short axis view, is obtained at around a scan angle of 30 to 60 degrees, and in this view, it is an excellent view for understanding the gross morphology of the aortic valve. We can see the left atrium, the right atrium, the tricuspid valve, the right ventricle in association with the aortic valve. in the center, and normally we see the Mercedes-Benz sign in case of a tricuspid valve, and in case of a bicuspid valve we can easily delineate the morphology. We can see the leaflet mobility, fusion, thickening, calcification, whether its calcification is limited to the tips of the valve, the body, or it's extending to the surrounding structures. All these things can be easily found out on the short axis view of the aortic valve. The number of cusps also can be easily identified. Then the scan angle is gradually increased, and we move towards the mediastinal aortic valve long axis view. In this view, again, we can in the gross morphology, we can see the aortic valve in association with the mitral valve, the left atrium, the left ventricle, and then the left ventricular outflow tract. And then we can see the thickness or the calcification, the leaflets of the aortic valve. The leaflet which is towards the far end is the right coronary cusp, and the one which is more proximal to the transducer could be either the left coronary cusp or the non-coronary cusp. We can apply the color flow Doppler as we've applied in this screen, and then simultaneously also assess whether there are any leaks or any stenosis. So this overall also for the gross morphological assessment uh, of the aortic valve, this view is an excellent view. Transesophageal echocardiography, in comparison to transthoracic echocardiography, overplays gross morphological assessment, whereas for any Doppler assessment, the transthoracic is better, because for Doppler assessments, the aortic valve goes in a far field. We go on to the transgastric long axis view, in which the aortic valve it is good for it's in a far field. So for the gross morphological assessment of the aortic valve, it may not be the best view, but for Doppler assessments like the pulse wave Doppler or the continuous wave Doppler, this view is excellent because it allows proper alignment of the Doppler beam to be with the jet, and so that the accurate measurements are most accurate. We'll be discussing about the Doppler assessments shortly. The deep transgastric view again is another view in which the Doppler beam alignment can be easily obtained, and again the 2D morphological assessment may not be very good, but then it's excellent for alignment of the beam, for assessment of the pulse wave or continuous wave Dopplers for the LVOT and the aortic valve. Other important views which should for any cardiac anesthesiologist, which we should be aware about for associated anomalies associated with the aorta, like aneurysms or dissections, we need to be aware of the descending aortic short axis view and the long axis view for assessing the descending aorta, and the upper esophageal aortic arch long and short axis view for assessing the aortic arch for any aneurysms, dissections, and the any associated anomalies. So coming to forming a stepwise approach for identifying any aortic valve pathology, is the first step is the 2D echocardiography, in which we have to keenly identify the aortic valve architecture, the aortic root, and the LVOT architecture, and then have an insight about the LV function and filling. Then assess the pulse wave and the continuous wave Doppler depending upon the area for assessment of valvular lesions and hemodynamics. Have an idea about the color flow Doppler and assessment of for the assessment of the valvular lesion, and then go on to 3D echocardiography. So the first pathology that we would be discussing would be the aortic stenosis. On gross morphology on 2D assessment, we can see in the mid-esophageal short axis view and the long axis view, the TEE strength rests on morphological assessment rather than functional assessment. And we need to evaluate the number of leaflets of the valve, whether it is monocuspid, bicuspid, tricuspid, is there any identifiable pathology like leaflet thickening, mobility, calcification, or whether there is any vegetation which is present on the aortic valve. And simultaneously, again, we can in this view we can apply the Dopplers for color flow Doppler as well. So most common pathologies include the calcific aortic valve or the rheumatic valve, or the most common is the bicuspid aortic valve, is almost seen in 38% of the cases. And in this view also we can perform the aortic valve planimetry in the short axis view, which allows rapid estimation for the anatomical aortic valve area. it often overestimates, and it's technically difficult to perform because in cases of poor cusp definition due to heavy calcium deposition, and then there may be acoustic shading and reverberation artifact. It's important to align to have a proper cut of the aortic valve, as any foreshortening or incorrect level application can cause overestimation of the aortic valve area if we are not cutting at the level of leaflet tips, which may not be visualized in the TE as the same plane. Then we need to assess the assessment of the aortic root, which all structures need to be assessed, include the left ventricular outflow tract, the aortic valve cusps, the sinotubular junction, the aortic annulus. Look at the sinuses and the proximal ascending aorta for any pathologies, dilatation, and then also look for any subaortic pathologies like subaortic membranes or systolic anterior motion of the AML. Then we need to take the aortic root dimensions. This is an ideal view, and identify any important to identify any calcium deposition on the mitral annulus or the aorta. So the measurements are usually taken in the mid-esophageal long axis view in a zoom mode, and usually preferred for an early to mid systole with a leading edge to leading edge direction technique. And we start from the LVOT, which is taken from 0.5 to 1 centimeter within the aortic annulus. Then we take the aortic annulus, the sinus, the sinotubular junction, and the ascending aorta. The next trivia is to identify this pathology, which is frequently noted in cases of aortic stenosis and has some severe implications in the post-operative period. Coming to Doppler assessments, once we are finished with the 2D gross morphological assessment, we need to perform the Doppler assessments, which are based on ultrasound waves, which are directed towards a moving object, and the frequency of the reflected ultrasound is increased or decreased based upon the velocity of the moving object, which is known as the velocity Doppler shift. And the other important principle which we have to be aware of is the Bernoulli's principle, which is based upon the conservation of energy. And this is used to usually derive pressure gradients, and the various measurements that can be obtained using this is the peak velocity, the mean velocity, peak gradient, mean gradient, and the velocity time integral. So coming to understanding the normal flow dynamics across an aortic valve is that the flow it's a cylindrical structure, and the area of which is given by the pi r square, and the cross sectional area is given by the pi r square, which is multiplied by the velocity or the velocity time integral to give the flow across it. And if we can make all these measurements, then we can get the an idea about the flow which is happening across the left aortic valve or the left ventricular outflow tract. So certain essentials for Doppler imaging is a good quality two-directional 2D image and ultrasound beam, which should be parallel to the flow. So that's why the concept of the deep transgastric and the transgastric long axis view is important, because they allow proper alignment, and it should preferably be within 15 degrees. And if it is within 15 degrees, an error only around 8% is expected, whereas if an angle of around 40 degrees gives us an error of maybe around 25%. So the view or optimal imaging is very important for any Doppler analysis to be accurate. And thus the transgastric long axis view and the deep transgastric views are the most preferred views for Doppler assessments. So we go on to assess the jet velocity, which can be either the peak or the mean transvalvular velocities, and it requires parallel alignment, as I just said. In cases of irregular rhythm, we will average the readings to 3 readings, and measurements are the disadvantage are that these measurements are again flow dependent. In low cardiac output state, it will produce low transvalvular velocities or may lead to underestimation of severity, and there may be a confounding effect of any lesions which are upstream. The waveform morphology also gives us an idea of the severity or the type of lesion. In severe obstruction, the Vmax occurs later in systole and the curve is rounded in shape, whereas in mild obstructions, a peak is an early systole and it's a triangular shape velocity curve. In dynamic subaortic obstructions like HOCM, it's a characteristic late peaking velocity curve with a concave upwards in early systole. Then we also have to take measurements for the transvalvular pressure gradients, which are the maximum transvalvular gradients or the mean gradients. These are calculated using the peak jet velocity and based upon the Bernoulli's equation, and Pmax is equal to 4 times the Vmax square. The mean transvalvular gradient can be measured using either the continuous wave spectral Doppler, which gives an average instantaneous gradient over time, and it can also be measured from the peak velocity, which is 2.4 times Vmax square. If there are high LVOT velocities, then we have to use the modified Bernoulli equation, as LVOT velocities more than 1.5 meter per second cannot be considered as insignificant. So the pressure in this situation will be 4 times V square. We subtract from the aortic valve velocity, we have to subtract the square of the LVOT velocity. Assessment of the LVOT is very important because LVOT diameter should be assessed, as we need to subsequently for calculating any flow, we need to have an LVOT VTI and the LVOT area, and it should be LVOT diameter should be measured at the same time point as we are measuring the LVOT VTI, and mid-esophageal aortic valve long axis view should be used, and leading edge to leading edge in mid systole. Subsequently, pulse wave Doppler assessment of the LVOT is performed in the transgastric views to measure the peak and mean pressure gradients, and obtain the VTI of the LVOT and the Vmax of the LVOT, and the sample volume must be placed at least 0.5 to 1 centimeter proximal to the aortic valve. Aortic valve area is then calculated using the continuity equation, and the basic principle is that the stroke volume of the left ventricular outflow tract will be equal to the stroke volume of the aortic valve. It's one of the most reliable techniques to measure the aortic valve area, and calculation of valve area requires the aortic stenosis jet velocity obtained by continuous wave Doppler, the LVOT diameter, and the LVOT velocity. The aortic valve area is then calculated automatically by a software in the echo machines, and gives us the aortic valve area by this formula. The dimensionless velocity index is a ratio of the velocity time integral of the LVOT over the aortic valve, or of the VTI of the LVOT divided by the VTI of the aortic valve. In cases of stenosis, we can see that if the dimensionless index is more than 0.5, it indicates mild stenosis, and less than 0.25 indicates severe stenosis. The basic advantage is that it is a flow independent parameter, and it is unaffected by changes in the cardiac output, and more so it's very important in patients who have low flow, low gradient aortic stenosis. It reduces the error related to the LVOT measurements by removing the factor of the cross-sectional area. Assessment of the coronaries also is very important in cases of aortic valve surgeries. We need to identify whether there is any normal or aberrant origin, then if there are any osteal related issues, or if there are any early bifurcation of the left main, where we need to guide the surgeon about the placement of the direct osteoplegia or direct cardioplegia cannulas, so that there is no preferential distribution of the cardioplegia to any particular area. 3D echocardiography for stenotic lesions allows better anatomical characterizations, like in number of cusps. It allows better localization of any pathoanatomy. Planimetry of the aortic valve can be performed. It has improved interobserver variability in comparison to transesophageal, and has additional information on prosthetic valves. And it's an important component for TAVI, because it allows accurate measurement of the area or perimeter of the aortic annulus, and it allows to measure the distance between the aortic annulus and the leaflet tips to the coronary ostia to rule out any coronary osteocclusion post-TAVI implantation. It also permits evaluation of individual leaflet architecture and range of motion throughout the systole and diastole. 3D echocardiography allows volume cropping of the aorta in the long axis at various levels, and anatomical, like the LVOT at the annulus, at the sinus and the sinotubular junction, and any anatomical change from one level to the next level can be easily assessed. Also, the intercommissural distance and the free leaflet edge distance is important to choose the tube size graft and valve sparing route operations. Another upcoming area of research is to calculate the aortic valve area using 3D echo, in which the stroke, instead of the flow, we measure the stroke volume using 3D echocardiography, and it's divided by the velocity time integral of the aortic valve, and it's basically used to eliminate the errors in the measurement of the flow through the aortic valve. by the measurement of the radius as it is squared. So real-time 3D echocardiography also has other important role in identifying the aortic area by using these adding up the Doppler to it. A third trivia question is try to identify the pathology. Yes, of course, it's bicuspid aortic valve, but what is the most common type of bicuspid valve, aortic valve? So once the all these assessments have been done, we come to classification of the severity of aortic stenosis. It's based upon the aortic jet velocity. If it's more than 4, we call it severe. Peak or mean gradients of more than 65 and 40. Important to have an indexed valve area of less than 0.6 because of the BSA. The valve area can vary depending upon if it's a small height individual or it's a very tall and high BSA individual. The dimensionless index also plays a role, and less than 0.25 indicates severe stenotic lesions. The other lesions that we are going to assess is the most commonly encountered are the regurgitant lesions, in which there is a leak across the aortic valve into the from the aorta to the LV. This may happen either due to dilatation of the aortic root, which are usually the type 1 pathologies, and the other type 2 or type 3 pathologies are associated with the aortic valve abnormality, like it may be rheumatic heart disease, degenerative calcific disease, endocarditis, or a bicuspid aortic valve, monocuspid or quadricuspid valve. As we had discussed earlier, that the important of the function of the root. So if there are any pathologies with the sinus, the sinotubular junction, or the ascending aorta, it can cause also aortic regurgitation, like seen in aortic root dilatation secondary to aortic aneurysms, dissections, Marfan syndrome, bicuspid aortic valve, in aging, in long-standing hypertension. So we need to go in a stepwise manner again for identifying aortic regurgitant pathologies. We need to have a qualitative assessment, a quantitative assessment, then identify other associated myocardial and valvular abnormalities, and then assess possibility for any leaflet preservation procedures. So the first step being assessing the gross morphology on 2D echo, and it's important to assess the leaflet morphology in terms of cusp thickening, calcification, mobility, valve coaptation, and whether there is any dilatation of any of the structures like the sinus, the sinotubular junction, if there are any associated dissection flaps which are present, how well the leaflets are coapting, and if there is a color flow Doppler can also be simultaneously applied and get an idea about where is the regurgitant lesion, where is the malcoaptation, and then subsequently obtain our measurements and then go for the aortic assessment for atherosclerosis, dilatation, aneurysm, or dissection flaps. In this 2D echo, we can also perform a qualitative evaluation using the Doppler. A color flow Doppler is applied and a leak is noted, and assess the direction of the leak, which the jet has various components which are important and we'll be discussing shortly, like the flow convergence, the vena contracta, the jet area, identify the jet width and the jet length. The direction of the jet can suggest us an underlying mechanism, whether it is associated with leaflet or pathologies or with aortic pathologies. Usually aortic pathologies cause a central jet, and leaflet pathologies may cause an eccentric jet. They may cause central also, but they more likely to cause eccentric jets. Then this can be color flow Doppler can be used to make a semi-quantitative assessment of the severity with the measurement of the jet width in the LVOT width, which is usually done in the mediasophageal aortic valve long axis view, in immediately around 0.5 to 1 centimeter below the aortic valve in diastole. We measure the width of the jet and divide it by the LVOT depth, and depth of more than this ratio of more than 60% is usually reflective of a severe aortic regurgitant jet. It has associated with it various pitfalls, because measuring too far down in the LVOT will cause us an inappropriately measured ratio, and then low Nyquist limits can cause an error of overestimation and excessive color Doppler gains. Multiple jets, it may cause an inaccurately determined LVOT width, and then eccentrically directed jets in which we cannot measure this lesion this ratio accurately. The other things that can be measured using semi-quantitative assessment are the jet area upon the aortic root area. Again, it has similar pitfalls. The only difference is that we are measuring the area of the jet in the cross-sectional view versus the LVOT area, and more than 60% is reflective, but then it's accurate but technically difficult and has similar lacunae in the other method. The vena contracta is the narrowest portion of the jet crossing the valve plane and is identified by visualizing the convergence zone of the color flow Doppler as it approaches the valve plane. And it is the method of choice for interoperative assessment because of its relative ease of acquisition and relative load independence. A vena contracta of less than 0.3 is indicative of mild regurgitation, and more than zero point 0.6 is associated with severe regurgitation. It of course is associated with various pitfalls like eccentric origins or non-circular origins. It may be inaccurate or difficult to determine, then imprecision, inter-individual variation, and then if there are multiple jets, then it becomes difficult to determine the severity, and then it's blood pressure dependent. It may vary with the changes in blood pressure and afterload. So coming to another trivia is that identify the type of pathology here and what are its effects. So coming to quantitative assessment for aortic regurgitation is one of the methods is the PISA method. I would briefly give some information about the PISA method, especially important for exam going people. It's based upon the hydrodynamic principle, and it's a conservation of mass and volume principle at the zone of flow convergence. As blood approaches a regurgitant orifice, its velocity increases, forming concentric hemisphere shells of increasing velocity and decreasing the surface area. There are two components of this PISA assessment. First is the proximal isovelocity, which is the Nyquist limit at which the convergence occurs, giving rise to the aliasing velocity. As we can see that there is a change in the color flow pattern as changes from blue to the red zone, and red is the area of the aliasing velocity, and so we need to identify this particular shell which leads to which is the proximal isovelocity, and the surface area of this shell which is where at which the isovelocity happens, so we need to identify the r value, which is the radius from the annulus to the from the leaflet tip to the area of the shell at which the aliasing is happening. So there are two steps. First is locating the color flow zone of convergence, which is first we need to optimize the area of interest, go into the zoom mode and adjust the depth so that we have the area of interest as the leaflet tips and the Doppler, the flow profile of the regurgitant jet. Then lower down on your Nyquist limit and set it to around 40 centimeters. And then identify the PISA shell at which the velocity changes from blue to red shift occurs first. Then we need to decrease the go into a zoom mode, which decreases the error of the radius measurement and obtain an optimal hemispheric flow convergence signal. And we need to time this signal to the time that it coincides with the peak aortic regurgitant jet velocity. Subsequently, we measure the calculate the proximal flow from these data, which is equal flow from the aorta will be equal to the flow which is going back into the left ventricle. So flow from the aorta will be equal to the area of the PISA multiplied by the aliasing velocity. The area of the PISA will be measured as the 2 pi r square and multiply it with the aliasing velocity will be equal to the flow which is going uh, through the regurgitant orifice into the left ventricle, and through this regurgitant orifice we can be derived by dividing the flow divided by the peak regurgitant jet velocity. And based upon this, the area of the regurgitant orifice, we can classify this as mild, moderate, or severe regurgitation. In EROA of more than 30 millimeters square is suggestive of severe aortic regurgitation. This can, if we multiply this aortic regurgitant orifice with the velocity time integral, it will give us an idea of the regurgitant volume. of the aortic regurgitation jet, which is known as the volume AR. And again, this also is suggestive of severity, and more than 60 cc of regurgitant volume is usually associated with severe aortic regurgitations. Regurgitant fraction is again can be easily determined by using the LVOT diameter and LVOT VTI, which we have already calculated, which is then used to calculate the LVOT stroke volume. And the aortic regurgitation fraction will be a ratio of the aortic regurgitant volume, which we had obtained by multiplying the EROA with the EROA, which we had just assumed with the velocity time integral, and then dividing it with the LVOT stroke volume. A regurgitant fraction of more than 50% is again suggestive of severe aortic regurgitation. Another Doppler assessment which is helpful in quantifying the severity of aortic regurgitation is the slope of diastolic spectral envelope. It reflects the pressure difference between the aorta and the left ventricle during diastole, and it is usually measured using the continuous wave Doppler in the transgastric views, whether in the long axis or in the deep transgastric views. The steepness of the slope and intensity of the waveform gives us an idea about the severity. If it's a flat slope, it's usually equal to a minimal diastolic gradient and between the aorta and the LV, and it is suggestive of mild AR. A steep slope or a high intensity slopes are suggestive of severe aortic regurgitations. Doppler-derived pressure half-time also is used to determine the severity of aortic insufficiency, and as the degree of regurgitation increases, the diastolic pressure decreases and the LV and diastolic pressure increases. So there is the diastolic pressure half-time is more accurate in acute aortic regurgitation, as the pressure half-time is influenced by chamber compliance in addition to the chamber pressures. In mild aortic regurgitations, the continuous wave Doppler there would be around more than 500, and less than 200 pressure half-time would be suggestive of, and a severe slope would be suggestive of severe aortic regurgitations. There are certain limitations of the deceleration slope method. First and foremost, it is affected by the SVR. So in cases of decreased SVR, it would be sepsis or effect of various drugs. It would have a steeper slope and overestimate the aortic insufficiency. In cases of decreased LV compliance, as in acute AR, there would be a steeper slope, which would also again overestimate the aortic insufficiency. And in cases of eccentric jets, we cannot apply the Doppler beam with the jet, and it would be inaccurate. The diastolic flow reversal also has been measured for quantifying the severity, and it's for flow reversal with mild degrees of aortic regurgitation. There is only brief reversal during the early diastole. As the severity of regurgitation increases, the flow reversal will become sustained and throughout the diastole at velocities exceeding more than 20 centimeters. And in severe aortic regurgitations, there is usually a prominent holodiastolic flow reversal. Assessment of feasibility of repair is important because aortic valve preservation procedures are increasingly being performed. There is a better understanding of the functional interaction of various components of the aortic root. Benefits of repair include no long-term anticoagulation, decreased risk of prosthesis-related complications, low operative mortality, and allowing for growth. TEE is uniquely suited to identify those aortic regurgitation lesions that are suitable for repair based on valve anatomy and the analysis of mechanisms of incompetence. We need to have proper understanding of various other findings associated with aortic regurgitation, which may be an increased LV and diastolic pressure causing premature closure of the mitral valve. Then have an understanding of determination of ejection fraction, measure the LV dimensions, assess flow reversal, and then assessment of other valves for any concomitant lesions. So to conclude the assessment for aortic valve, in a stepwise manner, we first have to have a gross morphological assessment, which is crucial. Then we need to go ahead and perform a thorough quantitative and qualitative assessment of the aortic valve. Then determine the lesion, what kind of lesion, stenotic lesion, regurgitant lesion, and then determine their severity. Determine the type of intervention which may be required, whether a replacement or a repair. Then we need to assess the other intracardiac structures, have an assessment of the left ventricle, have an assessment of other cardiac valves and the aorta, and then determine the adequacy of surgical repair which has been done. Thank you very much. So.
Thank you, Dr. Jatin. It was extensive coverage of aortic valve, and I'm happy that there are some questions. Shall we discuss those questions first?
Yes, ma'am.
Okay. Anybody can answer?
I mean, I will leave it to sir to decide if I can do that. If there's anyone who's a volunteer, then that's fine.
Can we go to those specific questions?
Yeah, so the first question was why is the aortic valve called a semilunar valve?
Yes.
So the leaflets, if we can see in this anatomical view, is that it's in the shape of they are in the shape of crescents, and if we can see that that's the reason why these are called semilunar valves. Both the aortic and pulmonary valve have a similar structure, giving it a half moon appearance, crescent or a half moon appearance. So that's why these are called as semilunar valves.
Yeah, I have one question.
Yes, ma'am.
Sometimes in bicuspid aortic valve, it looks as if the valve is one of the leaflets is prolapsing,
Mm-hmm.
but it's there is no true prolapse as such.
Yes, ma'am.
So what could be the reason for that
By
appearance?
Okay. Ma'am, bicuspid aortic valve have a different architecture. So they are very commonly associated with both stenosis and regurgitation. And because of their abnormal architecture, they may be associated with a prolapse, as you mentioned. But as such, why it would it normally it's not in all cases that would be it would only be
Yeah.
a particular
No,
cases.
even in the absence of regurgitation, sometimes we see as if it is prolapsing. As you
Mhm.
said, it is because of that anatomical variation of this valve.
Mm.
What was the next question?
The pathology which is associated here is an calcification of the iotomitral curtain.
Can you
It's
show that
yeah.
again?
So it's the extension of the calcification from the aorta towards the iotomitral
Excuse me.
fibrous curtain to the
We
aortic.
are not able to see your screen.
Not oh sorry, I'm sorry. I'm just going to share it again. Yeah, so it's the extension of this calcification from the aortic valve to the fibrous curtain, iotomitral fibrous curtain. In fact, even going up to the anterior mitral leaflet. So it's very important in patients who are undergoing aortic valve replacement in such situations that the while of the surgeon is removing this native valve, there are chances of injury to happening to the anterior mitral leaflet and while you're stripping off these calcifications. So we need to be very vigilant about new onset regurgitant lesions happening after aortic valve replacement in such situations.
Yeah, this is called teardrop calcification, is it?
Right, ma'am.
And how do we differentiate it from rheumatic calcification for the
Uh,
benefit of students?
the rheumatic calcifications would be present more towards the tips of the leaflets rather than towards the annulus, and
And
would be associated with commissural fusion, and
yeah,
uh, the basic difference would be the pattern of the distribution of the calcium.
okay. Your next question.
Yeah, so the third question was the type of most common type of the bicuspid aortic valve. There are three types of bicuspid aortic valve. The most common is usually the type 1 or the anteroposterior type, in which there is fusion of the right and left coronary cusp, which is almost seen in around 80% of the cases. The next most common is the right left type with the fusion between the right and the non-coronary cusp, and the least common is between the non-coronary and the left coronary cusp.
Yeah, I have one more question regarding this. Surgically, why we are interested to know the fusion type, non-fusion type? what is the association with calcification or regurgitation, dilatation? Can you explain few points?
I think I'll have to. I mean, I think you'll have to highlight me on that. This particular thing.
Yeah, as you said, fusion type, and that to right and left fusion, more than 70% is the incidence of bicuspid aortic valve. They have 3 sinuses, but there is fusion of one of these, 2 of these cusps. So one is when we are trying to diagnose, we have to diagnose it in diastole.
Mm-hmm.
When the valve is open, because the raphe will look like a normal valve in systolic examination. And there are types of aortic root dilatation. In these few types, the calcification is more common. Calcific aortic stenosis is more common with fused version of bicuspid aortic valve. Non-fused versions, they have less common pathologies. In some cases, it is diagnosed in indeterminate version, that is partial fusion. It may be diagnosed only in autopsy findings, or they may remain asymptomatic. So these few points, I know maybe sir can highlight some more points regarding why we are interested to know these different types, and how is it surgically or pathologically important to us. Yeah. Next question.
So the type of the jet, it is a lesion which is the right coronary cusp prolapse, and it is causing an eccentric aortic regurgitant jet, which is directed towards the anterior mitral leaflet, and this is a type 2 defect of the aortic regurgitation.
Okay. Any other questions are there?
No, ma'am. There's just these 4.
Yeah, it was interesting. Good. Thank you.
Thank you, ma'am.
Jatin and Parimala, it was excellent presentation of the subject matter. Very well done, clear concepts. And I have 2 comments. It's not a question. One is bicuspid aortic valve is a congenital lesion, but when you look into the incidence of congenital heart disease, VSD is quoted as the commonest congenital heart disease, but bicuspid valve actually is the commonest congenital lesion, but it does not manifest in childhood. So it's a problem with adulthood. So it doesn't figure in the commonest type of congenital heart disease. That's one comment. The second comment is that Jitin mentioned about the identification of the coronary ostia. In one of the cases we did about a couple of months ago, there was a single coronary ostium. And when we want to give a cardioplegia, we were searching for the other ostium. So if we can determine pre-bypass itself the ostia, it will be easy to tell the surgeon that we could make out only one, or we could see both the ostia. So that way it will help the surgeon when the ostial cardioplegia is delivered. These are the 2 comments I would like to make, but it was a very good presentation. Thank you so much.
Thank you, sir.
Are there any questions or comments from the audience? I would like to say that there are 2 announcements we want to make. One is we have the cardiac anesthesia same in Bangalore, Narayana on the 17th and 18th of December. And the second one is we are starting a cardiac critical care echocardiography course It will be a certificate course for MBBS people and a fellowship course for people who have MD. So this will mostly, it will have 4 components: TEE, TTE, lung ultrasound, and ultrasound for vascular access. The details will be provided if you write to the email I mentioned here, deanICAnational@gmail.com. Thank you so much. And also on the 4th of December, we may not have a Sunday webinar because of the parallel perioperative TE workshop being conducted at Medanta Medicity on the day 3rd and 4th. So 4th of December, we may not have it, but next Sunday, we will certainly have it. Any questions from the audience?
Good morning, Dr. Muralidhar. I'm Dr. Virinder Kumar from Delhi, sir.
Yes, sir. Tell me.
Sir, sometimes the window for the aortic ascending aorta valve are not adequate during the TE, particularly ascending aorta when we are going for Bental and some procedure. So how to measure it, sir? Sometimes it is oblique also. Correct measurements. Can you please guide us?
Yes, Jatin and Parimala.
So first of and foremost, usually the best modality for measurement would be a CT. We are going in with a procedure like Bentals. We would definitely like to have a CT done before it, and if we can make the pre-diagnosis. But coming to the same thing that this may come as an emergency, like in aortic dissections, where we don't have the time to take the patient for CT. We go in with the TE itself being the major modality for any dimensions, and in that case we have to go in with the upper esophageal views for making the measurements, keeping in mind the fallacies that there may be, we are only able to evaluate the only proximal ascending aorta because of the the bronchus, and we have to somehow just make our, because it becomes difficult in such situations with dilated aneurysms. There may not be an appropriate plane, or the entire with the, and we not get it in the same picture, the both the dimensions. So there are drawbacks of all. This is one of the major drawbacks. But then we have to go short and long axis views maybe, and then get cuts for making measurements in the upper esophageal views for Bental procedure.
Okay.
Yeah,
Parimala,
normally
yes.
we go to 5-chamber view, and then at that level increase the angle to 120 degrees, and then we can measure. A measurement we usually do inner edge to inner edge, but for us sending aorta, they say leading edge to leading edge is more appropriate and more it correlates with the CT values.
Okay, madam. Yes. Because the oblique view, if it is oblique ascending outer, then the measurement may not be correct. It has, that's the problem.
Yeah, Dr. P.A. Patil sir had taught me go to 5-chamber view, and
Yes,
from there you increase the angle so that you'll be getting a proper perpendicular dimensions.
Okay, madam. Thank you.
Actually, Netherlands group has come up with a view, that is a balloon filled with saline can be used in the bronchus to provide better imaging quality of the distal portion of the ascending aorta. And they have demonstrated that the stroke incidence has come down when they started to use this technique to identify atherosclerotic plaques in the ascending aorta. So this involves special procedure of inserting a catheter into the bronchus, and then left main bronchus basically, and then inflating that balloon with saline improves the visibility of the ascending aorta using TE. This is called A view. It has been suggested, but I don't know whether anybody is using it in routine practice.
Thank you, sir. Thank you so much.
Any other questions on the floor?
Sir, please tell me. Sir, please tell me how to inflate the balloon in bronchus, sir, through the tracheal tube, or how to go?
No, you have to put a catheter in the bronchus. Fiber optic scope is
Okay,
used.
okay,
And
sir.
there is a balloon at the tip, and you inflate with X amount of saline. I don't know exactly how much it is.
Yes, sir.
That removes the problem because of the interposing bronchus between the TE probe and the ascending aorta.
Okay, sir. Okay. Thank you, sir.
Have you seen it, Parimala? I have not seen it, but I did see it when I visited Netherlands. But they, especially in elderly individuals, they say that it has helped them to decrease the stroke rate because of identification of atherosclerotic disease.
Okay, so, I haven't seen.
So normally air in the bronchus, main bronchus, in double lumen tube, we generally put 5 ml of air as a volume of air. So I think that must be the volume for the saline also, sir, it seems. I'm not sure. I don't know.
We usually put 2 to 3 ml in the bronchial lumen. Maybe we can put saline there instead of air and try sometimes if we have put an endobronchial tube.
But still, the cuff, it will only fill the cuff area, but not the entire bronchus. Here you will be filling the entire bronchus with a saline-filled balloon. So the image quality is much better. There is no blind spot can be avoided. What they call is blind spot in the distal ascending aorta.
Yes.
Are there any other questions? If there are none, I think we can close it. Final comments by Parimala, and then thank you very much, Jatin.
Thank you, sir.
Thank you, sir, for this wonderful session. I thank Dr. Jatin for his excellent presentation and clear demonstration of basic evaluation of aortic valve. And thank you very much, sir.
Thank you. Enjoy your Sunday. We'll see you on next Sunday. Thank you very much.
Thank you, sir.